Alright, this is going to be a quick video on pain medication. So I'm going to kind of run through it pretty quickly because I know you guys have the holiday weekend, probably won't be watching this video too long. So first thing to remember is that pain is always subjective when the patient is conscious. So if the patient can tell you I'm having pain at 8 out of 10, that's what it is. You can't make any biases or assumptions based on what the patient says. Now, on the flip side, if the patient is sedated or unconscious, then the pain scale becomes objective based on what you can see on the patient. Are they grimacing? Are they in pain? Are they moaning? Are they flexing their arms? Then it's objective. If they can verbalize or in some way tell you where their pain level is at, it's subjective unless they are unconscious, and then it becomes objective. Next thing you need to remember is the difference between acute pain and chronic pain. I think we all kind of know what the differences are, but acute pain is generally going to be intense pain that occurs over a short period of time. You hit your elbow into the wall, you have acute pain. Chronic pain is going to be pain that has persisted for over 3 months. That's where you're going to get into arthritis, muscle pains, fibromyalgia, something like that. Chronic pain is generally going to begin to affect their adults and their ability to function appropriately. Next is different sources of pain. First one is the nociceptor pain. That is pain that is derived from injury to tissues. So that would be if you had a laceration, again if you cut yourself, hit your arm and things, that would be nociceptor pain. It's going to be something sharp and localized. Where neuropathic pain is just pain that's due to injury to the nerves. That's going to be numbness and tingling. The most common neuropathic pain we're ever going to experience as nurses is going to be diabetic neuropathy. So some sort of injury to the nerves themselves, not just a localized injury. So our goals for treating pain is not only to give analgesia, which is going to relieve the pain, but also decrease things that are going to also increase the pain. So mainly decrease the swelling. So you want to decrease the inflammation, provide pain relief, and then also a lot of pain relievers also give the added effect of being antipyretics to help decrease fever. You want to decrease the swelling because swelling is going to cause pain in and of itself. Your body swells up the tissue to get more blood flow to the tissue in case there's been any sort of external injury. More blood flow brings more nutrients, more oxygen to the area, so it'll help it heal quicker, but also will bring white blood cells in case there's been an external damage. So, and then also with the swelling, you're also going to just bring pressure on nerves and area, which this one itself is going to lead to pain. So by decreasing the inflammation, decreasing the swelling, you're going to bring about pain relief, but you also still want to block the pain receptors. So next thing you remember is it's a slide on basically the World Health Organization analgesic ladder. So analgesic is just basically, or analgesia is a term that's used for any sort of pain relief. Usually people think analgesics to think of opioids and things like that, but technically anything that gives pain relief is considered an analgesic. So the World Health Organization pretty much dictates, for pain, 7 to 10 use stronger opioids like your morphine, oxycodone, or hydromorphone dilaudid. Sometimes a strong, potent opioid. And after pain's a little less, 4 to 6, then you can use a weaker opioid like codeine, a smaller oxycodone with acetaminophen, some of those combinations. Also, and then 1 to 3 should just be a non-opioid pain reliever like an NSAID, aspirin, Tylenol, something like that. With all of these, you should always be trying to treat the pain first, non-pharmacologically. Use some sort of adjuvant along with it. Do they need music therapy, aromatherapy, repositioning, ice packs, heating packs, something along those lines? Always try to treat the pain non-pharmacologically to help decrease symptoms later on. First things we're going to talk about are non-opioids and NSAIDs. So one thing that it's important to remember is that acetaminophen, even though it's a non-opioid pain medication, it is not an NSAID. Acetaminophen does not have anti-inflammatory effects. So remember, NSAID stands for non-steroidal anti-inflammatory drug. That basically leaves aspirin, which is always abbreviated as ASA, or generation NSAIDs, which is ibuprofen, naproxen, over-the-counter medications. Okay. So the first one to kind of look at is our aspirin. I have the picture of the aspirin lady in here. So the things to remember with aspirin is that it's going to do a variety of things. One's going to be an anti-inflammatory, which we already covered. Inflammation leads to swelling, which leads to further pain. So it helps decrease swelling. It's also an analgesic, so it's going to help control the pain. It's also going to be an antipyretic, so it's going to help decrease a patient's fever. Remember, a fever is a full fever is anything over 101.5 or greater, and a low-grade fever is 100.5 or higher. Aspirin also has antiplatelet aggregation as a side effect, meaning it's going to prevent platelets from basically sticking together. What we usually use aspirin, we use it for after a heart attack. I always give them 325 of aspirin to help decrease that clot that caused the heart ischemic attack from getting worse. The problem with using aspirin is it has that platelet aggregation effect, which means it's also going to make it harder for your body to clot in types of damage. So if someone has pain from a laceration, we don't want to give them aspirin because it's going to increase the bleeding. That antiplatelet aggregation is also going to lead to complications with bleeding. So it's also going to affect your platelets. It's going to lead to thrombocytopenia, so it's going to affect your platelet counts. Aspirin is also very harsh on your stomach, so it can lead to ulcerations and just stomach breakdown. So you always want to be aware of any sort of stomach pain or ulcerations or signs of an upper GI bleed. An upper GI bleed is either they're going to vomit up coffee ground emesis, or they're going to have black tarry stools. And that is the signs of an upper GI bleed. If they had a lower GI bleed, then it'd be frank red blood. But aspirin, we're going to look out for signs of an upper GI bleed. Also, if it becomes toxic, they take too much aspirin, they can get tinnitus, which is basically ringing in the ears. So the first sign that someone's taking too much aspirin is going to be that ringing, the dull ringing in their ears. That's always something you want to assess for. So the contraindications and precautions for NSAIDs and aspirin in general is for all NSAIDs, you're going to be careful of clotting disorders. It's all anti-inflammatories. So all going to have effects on your clotting. So you want to make sure they're non-heparin, non-warfarin, don't have any clotting disorders. You also want to avoid use of aspirin in children. Giving aspirin to children can lead to something called Reyes' disease. Basically, if they have a viral infection under the age of 8 and they take aspirin, it's going to lead to a cognitive disorder based on the body's reaction with the virus along with the aspirin. It's also going to lead to potentially kidney failure. You also want to be aware of any sort of liver failure in regards to the anticoagulation effects. Remember, your liver makes the clotting factors. So if you have liver failure, your clotting factors are already going to be impaired. So it's going to make things worse. Remember, we measure our liver counts with our AST and ALT, and kidney function tests are going to be your BUN, creatinine, and then also your urinary output. So basically, I want you to go through and think about when What do you want to look for when someone's taking an NSAID? What would you be concerned about? What sort of histories are you going to want to know about the patient? It's going to be, do they have a history of bleeding? Are they on warfarin? Do they already on blood thinners? Do they have liver kidney dysfunction? It's going to get potentially worse. Do they have a history of GERD? Gastric reflux. That's going to be a complication for the stomach acid. In labs, you already said we want to monitor your platelet counts. You want to monitor your B1, your creatinine. You want to monitor your AST, your ALT. Another thing you want to monitor is the fact that, is it giving pain relief? Is it working? Alright. Next is going to be acetaminophen, Tylenol. It also can be abbreviated as APAP. It's the standard abbreviation for Tylenol. The standard abbreviation for aspirin, remember again, is ASA. All of those can be common abbreviations for the medications. So Tylenol is going to be used for patients that they either have some sort of clotting disorder, so they can't take aspirin, they can't take ibuprofen, they can't take naproxen, or they're starting to have some complications with the bleeding. So we're going to give them Tylenol. It's important to know that Tylenol can be very dangerous. So it's going to be extremely hepatotoxic. So you can only dose your patients out to 4 grams a day or 4,000 milligrams a day. Anything more than that can become toxic. If your patients ingest a toxic amount of acetaminophen, there is an antidote. The antidote is going to be acetylcysteine or Mucomyst. It's going to also be a respiratory medication we're going to cover later on. It's probably in my respiratory video, but Mucomyst, acetylcysteine is the antidote for Tylenol overdose. You can a good way to remember it is acetaminophen, acetylcysteine. It kind of starts the same way. So overdoses of Tylenol are going to lead to hepatotoxicity, and so you never want to mix Tylenol with anyone who has liver disease or alcohol abuse, and no more than 4 grams a day. Next you can have tramadol. Tramadol is basically, it's going to be a central acting non-opioid, so it's not going to be a narcotic. It's a very strong analgesic, but it is not an opioid. It will bind to the opioid receptors, so it kind of works the same way. It's an opioid agonist, but it's not actually an opioid. It just binds to receptors, leading to pain relief. So when you see tramadol, I think of it as it's going to have some of the same side effects as opioids because it's binding to the receptors, but it's not an actual opioid. So there's no complications of addiction or withdrawal. And it's a lot safer. There's no real true side effects. Next are the opioids. These are your narcotics. These are the ones that people always kind of think of when they have pain. They always want to have some sort of opioid or narcotic. This is going to be your morphine, fentanyl, codeine, oxycodone, hydrocodone, hydromorphone. These are all very strong analgesics. If they are used properly and thoroughly and a patient is assessed, the chances of them becoming dependent and over abusing them are very slim. But they have to be used appropriately and properly assessed. There's a huge opioid epidemic in America, and now what a lot of hospitals are doing, and they're not prescribing them, or they're only prescribing them for a few days, and they give them something like tramadol, and then just tell them to go to Tylenol. They're really starting to crack down on how much they give. So opioids, remember, are a Schedule II medication, which means they can be prescribed, but they have a high complication for abuse. They're going to give analgesics, they're going to give pain relief, but they can also lead to sedation. They're also going to give someone that euphoric effect, which is going to basically be like they're going to feel high, which is why they can be abused. The major complication with opioids is going to give respiratory depression. It's going to basically sedate your body down so much that you're going to impair the respiratory drive. So your antidote for the opioid overdose, or just respiratory depression from too much opioids, is Narcan, naloxone. So if their respiratory rate's less than 12, you can give Narcan or naloxone to help reverse the effects of the opioid. With opioids, people can have a drug tolerance. Remember, a drug tolerance is where something like the same dose of medication no longer becomes effective for the patient. They're going to need a little more to get the same pain relief before. It's not that they're abusing it, but their body, the opioids you gave them, didn't give the same pain relief. So they have to require a higher and higher dose for the pain they have. You should only really see that with someone who has chronic pain issues. And if they have chronic pain issues, again, remember, we want to try and treat the chronic pain more ways than just giving them medications. So the main precautions for infants is going to be any sort of renal failure, because it's going to impair their excretion of the medication. So it's going to build up more in their body, leading to further sedation. And remember, whenever you have CNS sedation, you always want to be aware of not just their respiratory status, but all of their vital signs, their blood pressure, their heart rate. They're going to have a loss of consciousness. They're going to get really sleepy. So you're going to want to be aware for risks of safety, because they're going to be really sedated. Opioids are also going to lead to constipation. There's opioid receptors in your GI tract that use different things. And so even though you're stimulating, opioid receptors are for pain, but they're also in your muscles. So basically you're stimulating the opioid receptors in your GI tract, which is going to lead to decreased peristalsis and constipation. So whenever you give someone an opioid long term, we're going to want to give them some sort of stool softener, kind of help prevent complications from the constipation. It's also going to lead to potentially urinary retention and decreased urinary output. So you want to make sure your patient is at least having the 30 cc's an hour for your shift, generally 240 every 8 hours. You need to make sure they're actually having enough, because again, it's that CNS depression. It's going to slow everything down. It's also going to depress the CNS to the point where if they have epilepsy, they're going to be at a higher risk for a seizure, because it's decreasing that seizure threshold. Alright. So next is what I already kind of covered. It's naloxone. It's Narcan. This is going to be, it's an opioid antagonist, which means it's going to block the effects of the opioid. It actually works fairly quickly. As soon as you give it to them, it'll start blocking the effects. And if they are overdosed, and that's why someone's unconscious, or if they have respiratory depression, that's how they can get out. Or if it's used, if they're during pregnancy, during labor, the mom had an epidural. Epidurals are generally going to be some sort of opioid. The baby is born and is having respiratory depression. You can give a small dose of Narcan, reverse any opioid inside the baby until it's time to filter it out, bring it back. Next is just a picture of the droopy deuteronomy. Basically, it's just kind of the various D's that are going to be shown to be caused from opioids. Decreased respiration, dizziness, drowsy from the sedation, potential drug dependence. It can lead to the body's physical need to have the medication. Decreased blood pressure, decreased heart rate, and also decreased peristalsis and urine output, so constipation and urinary retention. Lastly is just a review of tolerance, dependence, and addiction. So tolerance, again, is patient took 5 milligrams of oxycodone to get the desired effect. Now that 5 milligrams isn't having the effect that it had before, it's not giving the analgesia. So now they require 10. And then 10 stops working, they become tolerant to that, they need 15, and so on and so forth. Dependence, that's when your body begins to depend on the medication to function. either physically or psychological dependence. There is a difference. So when you take the medication away, that's when the body starts going through withdrawal symptoms when the drug's stopped. Addiction, that's more of your psychological need to use the drug for non-medical reasons, such as that euphoria from the opioid. It makes them get that high. Lastly, for the LPN students especially, it's just going to be a quick review in anesthesia medications. We're not going to get into any sort of anesthetics, but just be aware of the difference between local and general anesthetics. Local anesthetic is just going to be pain relief in a small, localized area. So if you had dental work, they give you a local anesthetic. It's not going to knock you out. It's not going to become unconscious. It's going to give you the minor pain control for the area you need for whatever needs to be done. In general anesthesia, that's when you're completely sedated and you're completely unresponsive and you're complete pain control. You're going to be paralyzed. You're going to be completely out. If there's any questions, feel free to let me know. Email me, text me, call me, whatever. Let me know. Have a good week.